incredibly honored to be here. Howard Schumann taught me about mind-body syndrome in 2011. I put on a seminar called A Course on Compassion, Empathy in the Face of Chronic Pain. And I've been doing this work for about 15 years, but I had no idea it was mind-body syndrome. And Howard was my keynote speaker. And I go, wait a second, this is mind-body syndrome work that I have been doing. So since then, the whole process came together in a very powerful way. And Howard's been my mentor. He's also a very difficult speaker to follow, so I'm going to try today, Howard. That's just really not fair that you did this to me, Dorothy. And then Dave Clark's been another recent mentor for me, which has been fantastic. He and I put a seminar together on in Seattle last October to the American Society of Osteopathic Physicians, and it went really nicely. It's some very nice results from that. And then I know a lot of people on the round table here, so I'm really excited about being here and meeting people personally. I feel much better about protecting myself. Where's Nick? He's a samurai guy who I know how to keep my head on straight now. It's interesting the evasive action that you do in your martial arts. But no, we've had a wonderful time here in London, and I was in school here 40 years ago. I've not been back since then. And since then, they've sandblasted all the buildings. It was black back then. It's very interesting coming back and seeing a white London, so it's very interesting. So this is a talk that I really cannot put into words how deep a change has happened to me in the last 3 years, but I'm going to try and tell you some stories. And the first one is a gentleman who I have gotten to know recently in the last 2 years. His name is Mark Owen. He is an author of a book called The Cry of the Kalahari. This book has sold over 1 million copies. At 29 years old, he spent 23 years in Africa saving elephants, lions, you name it. He and his wife took a Land Rover, no guns, a tent, some food, and went out to a part of Africa that was so remote that the animals did not know humans. Quite a guy. He came back to Idaho and bought a 700-acre reserve to raise grizzly bears and wolves. By the way, the ranchers don't like him very much out there. And so he came back to Idaho and he broke his back while he's thrown off of a horse. And he was not paralyzed, but he spent overnight in the mountains. He had hypothermia, he almost died. And had a fusion done of his spine from thoracic 8 down to L2 and developed chronic pain. That was 9 years ago now. So then they decided to add on this little device here. They did an L2-3 fusion about 2 years later for, quote, degenerative disc disease and pain, which made his pain 4 times as bad. Really incredible pain. And he went and saw 2 surgeons about 2 years ago that both recommended that he had a T4 down to pelvis fusion for back pain. And the basis for that was this disc degeneration here and here and here. But mind you, I'm a deformity surgeon, and you have to be deformed to do deformity surgery. Right now, there's a disturbing trend of doing deformity surgeries on straight spines for pain. This was one of them. So he came to me, and he goes, I looked at his spine, I go, this is fine. I mean, you have degenerative disc disease, it's normal. This is a chronic pain problem. I handed him my book. And you'll see in this book there's an expressive writing exercise that's been documented in over 55 research studies. We simply write down your negative thoughts and you tear them up. And it's something to do with the unconscious link that breaks up these pain circuits. It's documented again out of Harvard. In my own personal experience with chronic pain for 15 years, I had 16 of these symptoms, by the way, that Howard talks about. It was a disaster. The only thing that pulled me out of the hole was this expressive writing. What I didn't realize is the data is so deep on this. And so I said, look, Mark, just read my book. And by the way, tonight, take your piece of paper and simply write down your negative thoughts. And he's a scientist, he's a PhD scientist. He just says, what? So we're going from 2 surgeons saying 10 hours of surgery to going home and writing. So his girlfriend goes, look, just give it a try. For the first time in 8 years, his sleep was better. His pain was down by 20%. By the 3rd day, his pain was 80% gone. 2 weeks later, his pain was gone. What the surgeons didn't know is that the reason he left Africa was because the gangsters, mobsters, poachers were threatening his life. This guy's Indiana Jones. He's out on a helicopter at night with machine guns hunting poachers. This guy's a tough guy. His wife developed PTSD. She could not take it anymore. What was going on in his life at that time was a horrible marital situation. He's going through divorce. That's what was really going on with this guy's life. And again, Howard's telling me a lot about this timing of other events. So about a month later, I said, look, Mark, I'm doing this seminar in New York at the Omega Institute. And it's a 5-day seminar that my wife and I and Dr. Luskin out of Stanford have put on together. It's based on structure, hope, forgiveness, and play. Pain pathways are permanent, but guess what? So are play pathways. It's been one of the bigger transitions in my own personal experience was, look, just have a good time. So I'm up here talking to you, and this sounds a little nerve-wracking, but guess what? It's a great opportunity, and I'll get to it in a few minutes. I'm going to have a good time, right? So really, I enjoy my staff more, I enjoy my patients, and just making a decision to have a good time. All of us have play pathways in our brains. So I didn't know what I was doing, so we just simply put in Fred Luskin from Stanford, who wrote this brilliant book on forgiveness called Forgive for Good. I gave some didactic work. I used a lot of Howard's type material. And then my wife turned out to be the star of the show. She's a tap dancer and a clown and a mime and a tango dancer. And she taught us somatic tools, simply how to relax and laugh and play. So Mark showed up to the Omega Institute, and we did this Friday in our little think tank called the Cup Song, and none of us had heard of it. And so it's simply a shared experience where none of us know what we're doing. My wife happens to be a rhythm genius. It took me 3 days to learn this crazy thing. And everybody learned it Friday in about 10 minutes, which made me feel even better about myself. So we just had a great time, and people started to laugh. We have run 30 people through the seminar in 2 years. We're doing it again in July. And everybody shifted out of their pain pathways in 5 days. It was unbelievable. And nothing to be expected. And when they went back home to the triggers, they went back to their pain pathways. But at 1 year out for one group and 2 years out for the other group, about 75% of them are out of their pain pathways still. And it's sustained. These people had 5, 10, 15, 20 years of chronic pain. These are the worst of the worst. When I looked at the pain questionnaire, and I used Howard's 33 symptoms questionnaire, probably the average was about 10 symptoms, sometimes 15 and 20. And I just panicked last year and go, what, this is insane. So this is Mark, and he sort of hated the Cup Song, by the way. But after Omega, he emailed me last week. He's going to write the preface for my revision of my book, and he's riding his horses, working out. He has zero pain, zero limitations. So he went from 10 hours of surgery, 8 years of chronic pain. In 2 weeks, he's pain-free. It's a big deal. That's $200,000 worth of surgery. This guy had a fusion from his neck to his pelvis. It wouldn't have worked very well. Basically, what's really interesting about this whole mind-body syndrome concept is actually the standard of care that's been in the medical literature for at least 60 years. This is not new. It's what the data says we're supposed to be doing. Right now, the common indication for surgery is failure of conservative care. How many have heard that term? Failure of conservative care? Okay, well, think about this for a second. I was in Philadelphia at a North American Spine Society meeting back about 10 years ago, and they presented 2 horrible papers on fusions for back pain and workers' comp. And somehow they said, well, it seems to work. I'm going, okay. But I also realized that you have to define conservative care first before you can fail it, right? I mean, what is failure of conservative care? So right now, just sort of the general consensus is, well, everything else has been tried. Maybe 3 months, 6 months of trying whatever. Random therapy, random injections, psychology visits, whatever. Not all aspects of pain have been addressed. They certainly have not addressed what Dave and Howard have talked about the different adverse childhood events, et cetera, and especially the mind-body syndrome symptoms. Of course, myself as a surgeon, I didn't have any clue. I would not be standing here unless I had not gone through 15 years of chronic pain myself, and I happened to meet Howard, who happened to be my keynote speaker. I had no idea. There's not one part of my education, including a full-fledged spine fellowship at the #1 spine fellowship in the world at the time in Minneapolis, that taught me anything about chronic pain. Nothing. So first of all, chronic pain is not acute pain. And I'm just going to reinforce a different aspect of what Howard talked about. Now, Howard actually sent me this article. Is that out of Chicago, there's a group that publishes about 2 papers a month on functional MRI scans and all sorts of bodily symptoms. And basically, they took a prospective study with functional MRI scans. They looked at a group that had back pain for less than 2 months. Then they scanned another group who had chronic pain for more than 10 years. And they found out by prior studies that the back pain, of course, localized to the pain center. But the chronic pain, every person had the pain only in the emotional center. Then they took the group of acute pain patients and took about half of those, and they scanned them every 3 months for the next 12 months. 19 of those patients recovered, but 20 of those became chronic. That's a lot, by the way. Half of those acute patients became chronic. And what they found out is that in the resolved group, of course, the pain center went dormant, but in the chronic group, the pain center became dormant, but it shifted completely to the emotional centers. So that shift occurred within 12 months. So that makes sense, right? If you put your hand over a hot stove, you have anxiety, and you pull away your hand, right? And your anxiety is resolved. What would happen to your anxiety if I forced you to hold your hand over that hot stove? You go up, but what would be your next emotion? Anger, frustrated. But in chronic pain, this is where you're at. You're over that hot stove the rest of your life with no hope of getting away from that stove. And that's where Dr. Sarno talks about the anger and the rage. I call it the abyss. And when I don't think it's a psychological diagnosis. People cannot put into words how deep their frustration is about not getting away from this hot stove. And you say, well, maybe this is a little overdone, but not really. I mean, chronic pain is a bad thing. It's terrible. You're trapped. So the first problem that is physicians is that chronic pain exists in the emotional center, not the pain center in the brain. It just exists in a completely different part of the brain. So when we do spine surgery, guess what? We're doing a structural operation on the emotional center in chronic pain. And we know statistically from San Francisco, Dr. Schafferman's slide, that the success rate for back pain surgery is 15% with history of abuse, et cetera. And placebo effect's about 20 to 30, 40, 50%. I mean, that's not even a good placebo number. So I was sitting in Journal Club in 1984, and I cannot find the original article, but in Journal Club, they point out this fact that I was a young orthopedic resident, doing total hips, total knees, all these types of structural things. And this review article in the Journal of Bone and Joint Surgery pointed out that psychological factors are a better predictor of success in spine surgery for back pain than the anatomic lesion. I'm going, what? I mean, how can that be? And I still didn't get it for another 20 years. But it's been around for a long time. That was 1984. There's another 3 articles here, and there's many more after that. But think about this carefully. So, people keep talking about in mind-body syndrome that we need more research studies. I'm going, really? Think about this carefully. There's an article in 2000 on spine where Linton pointed out there's 913 articles between 1967 to 1998 that documented the link between pain and psychological distress. 37 of those are high quality, and the results are very, very consistent. We all know this. I know I'm preaching to the choir here, but guess what? We do not need another research study. We just don't. Let's just take what we know. Let's just do it. This is right here. So the other problem is that I spent 2 years in internal medicine, and every break we were obsessed about surgeons. We just talked about surgeons all the time. They made too much money. They were arrogant, they were difficult, and here I am. Now don't talk to my wife, because I can be difficult. But in the surgeon's defense, has anybody seen that movie Whiplash by chance? Okay, I would recommend, it probably isn't over here in England as much, but my goodness, it's about a very high-level music school, and the director is as abusive as you can imagine. That is the way surgeons are trained, at least in the United States. I don't know what it's like over here, but it is abusive. It's a disaster. So Howard was with that course with me on the course of compassion, where they found out that the compassion index dropped the third year in medical school, that Jefferson Compassion Index. And so we're beat up, and we're trying to survive. And guess what? We sort of lose connection with ourselves, with people around us, particularly our patients. But it doesn't mean we're not confident, right? So we've sort of detached a little bit, but guess what? When you talk to any surgeon, they really think that they can tell you whether a person's a good surgical candidate. We just sort of know. They'll go, we won't operate on somebody that we don't like. Well, my first thought was going, well, that's sort of biased. I mean, that should not be a good criteria. But they gave this DRAM index, which was a combination of a somatization index and a depression score, to 125 orthopedic patients, and they identified a certain group that were distressed or at risk. Then they had the surgeons predict ahead of time who is at risk versus normal. The surgeons could predict psychological distress 26% of the time. Another study out of Utah showed 45% of the time. What was disturbing, it did not matter whether it was a medical student, junior faculty, senior faculty, or veteran surgeon, it didn't matter. No surgeon in clinic could tell who was at risk. It's gotten worse. When I first started surgery now almost 30 years ago, is that we did psychological testing, we acknowledged the problem, we would go through quite a bit of work on this stuff, and I swear the last 10 years I've not seen a surgeon evaluate a patient psychologically at all, don't even acknowledge it. So the paper came out of Baltimore showing that only 10% of orthopedic surgeons are using psychological screening. And the community-based surgeons are a little bit better than the academic surgeons, but neither one are very good. And obviously consequences, depression, recovery, complications, et cetera, are right there. So how many have heard the concept that surgery is sort of the definitive surgeon answer? It sort of felt like, well, everything else has been tried. Let's do the really big definitive operation. And in our culture, at least amongst primary care, that's sort of the feeling among patients about primary care, et cetera. And I'm going, really? And I'm going to give one of about 10 papers here, but this to me is the gold standard done in 2006 out of Stanford. And Eugene Kerrigan is an incredibly precise researcher. He did a prospective study looking at 32 unstable isthmic spondylolisthesis of more than 4 millimeters of translational instability. That's a lot. Only back pain, no radicular pain. Then he did incredibly carefully controlled discography, low pressure, very, very well documented, one level, and guess what? He ruled out psychological pathology. So this is the best group of patients you can get. The success rate in the unstable spondylolisthesis was 72%. I mean, that sounds pretty good, right? But really, if it's unstable, it should be 90-95% success rate. So I thought that was a little bit low. But for discogenic pain, straightforward patient, very carefully controlled discography, one level, mind you, the success rate at 2 years was 27%. I mean, how many of you would undergo a spine fusion if the success rate was 90%? Okay. How many would do it at 27%? So I first found this data out. So I'm one of the few surgeons, by the way, that's been on both sides of this fence because I spent 10 years doing fusions for back pain. Seattle had 9 times the rate of spine fusions for back pain as any place else in the entire country. It's a lot of surgery. And my results weren't very good, and everybody was doing it. That's why I was trained. In 1993, my workers' comp, Gary Franklin, the medical director, published a study showing the return to work rate 1 year after a spine fusion for back pain was 15%, 1-5. So I stopped. From 1993, I just simply stopped doing spine surgery for back pain. We also know that there's a diminishing returns. Every time you do an additional surgery, the success rate of that surgery is half of the surgery before. Well, if you're starting with 27%, that's really not very good. Well, I just found this paper out about 6 months ago. This has been out also for a long time. About the last 10 years, there's data showing that you take any surgical procedure, amputations, thoracotomies, mastectomy, inguinal hernias, you can actually induce chronic pain Remember, these are relatively painless operations, particularly a hernia, uncomplicated hernia. You can induce chronic pain up to 40% of the time. It's unbelievable. And then about 10% of that can actually turn out to be a long-term chronic problem. The risk factors were the severity, having preoperative chronic pain, emotional vulnerability, catastrophizing, et cetera, not news to this group, but the risk factors are right there, and guess what? They're treatable. So basically, inducing chronic pain is rarely mentioned as a complication of a surgical procedure. I had never heard of it, and I haven't run across this article. I think one of the TMS wiki people sent me the paper, and it's several dozen papers actually documenting the same thing. So it's interesting, when Dave Clark came to Seattle and Gordon Irving and myself, Joe Conoco, and I've talked to Howard, everybody does this a completely different way, but I think there's basically three basic concepts that help you solve chronic pain. And the first one's education, and it does two things. Gordon Irving and myself have been working on this pain project for a long time. Gordon's the head of our pain center. We have found out that the only factor that seems to predict success is people's willingness to engage, period. End of story. Take responsibility. So when you ask people to read a book or go to a pain puzzle class, et cetera, and they don't want to do that, you just have to stop. It took me a long time to figure this out, a super long time. I thought I could fix anybody. And so what happens is I simply ask them to go to an educational class, read a book, whatever it is. If they say no, it's just done. So it turns out in an odd way that chronic pain is actually incredibly time efficient, because if they don't do that, they don't come back. That's time efficient. And if they take responsibility, it's just fun, and they're doing it mostly on their own, that's time efficient. And I'm not necessarily proud of the time I don't spend with patients, but actually, in an odd way, it's actually worked out better. The less time I spend trying to save them, the better it's worked. Then the other answer is there's never one answer for chronic pain. There's a bunch of variables that affect chronic pain. You have to address every one of them at the same time. Think about that carefully. They say, well, acupuncture didn't work. Well, it could add 10%. And if you're doing acupuncture but not sleeping, that's not going to work. So you add the sleep, the stress, the acupuncture, physical therapy, medications, you're adding all that together, you come up with a really nice result. But the final part is patients are individuals. Their lives are complicated. They have to take control of their own care. That's the key. So there's a paper just done last year, 2 years ago, out of Texas. Dr. Gatchell is very well known, and Dr. Meyer very well known in the spine surgery world for their rehab. And the politics of this are very interesting, because this is done out of Texas Back Institute, which is basically a spine fusion machine, their factory there. And they basically found out that they could improve outcomes from 25% success rate to 76% success rate, almost 300% improvement with return to work, opioids, less future surgery, and healthcare. But both groups had surgery. They didn't have a group that just had these interventions. So it looks like that surgery actually probably didn't really add very much, if anything at all. So we put a process in place in Seattle, which has been very surprising to me, called prehab. And you simply take the data that's there, and we make no decisions on the first visit. I don't know what it's like here in the UK, but a lot of surgeons want the testing done ahead of time. They want to be able to make that one decision on that first clinic visit. It makes no sense, right? I mean, I don't know them, they don't know me. It makes no sense, particularly if it's a complication. I mean, how do you deal, if you don't know the patient, they don't know you, particularly don't know the background, how do you make the decision on the first visit? So we never make a decision on an elective surgery in the first visit. We talk about the education. Then if somebody has a structural problem, which means I can see it with matching symptoms, that's the only time we do surgery ever. I was also instrumental in Seattle, working with Blue Cross of Washington, developing, I think, the only policy in the country that says no surgery for back pain. We don't care what the conservative care has done. We are not paying for surgery, period. Then we do this prehab for about 6 to 12 weeks. Some people, we've done it for a couple years. There's no really time limit to it. We want the back pain diminished, at neck pain, thoracic pain, back pain diminished by at least 50%. I'm very clear every time, every patient, surgery will not help your back pain. We want the anxiety actively treated, preferably scores actually dropping. We don't want them off narcotics, although obviously that's preferable, but we at least want it defined and stabilized, and we want them to sleep. I can't tell you the number of patients that have come to me from the rehab doctors that haven't slept for 2 or 3 years, and they're getting ready for surgery. I'm going, that makes no sense, right? So this is a book that I wrote 2012, and basically it's my story to chronic pain. And it's just basically a framework that just organizes a complex topic like chronic pain into 6 different sections, so it allows the patients to understand the 6 different parts and take control of their own care. And I realized that people were reading the book, but nothing was really happening, so I developed a website that's open resource, no registration, no fees required on this one, where basically there's 5 stages. It's just a very self-directed process. And between the book and the website, probably 70% of the work is being done. So Joe Conoco, Jennifer Lee, myself, we have 6 of us in Seattle now that do mind-body syndrome work, basically use this book as a framework, and then we become coaches. And it's fun. I mean, we had the best time with this. We had the same results that you talk about Howard and George. I mean, it's unbelievable how well these patients do. I'm sure a lot of people in this room have had the same success. It's just unbelievable. I gave a talk at Mayo Clinic 2 years ago on enjoying the management of chronic pain. It is delightful to take somebody with no hope, give the correct diagnosis, and watch them not only come back to life, but actually expand their life in areas they never even dreamed of. People getting remarried, back to new careers, back to work, whatever. It's unbelievable what happens. So we address all the variables, which is sleep, the stress, medications, the physical conditioning, and the overall life outlook. Again, this is a whole different lecture course I'm not going to get into today, and we'll be covering it the rest of the day. But you take every variable that affects pain and address them at the same time. What's been interesting is that my better outcomes are better. I used to do the perfect operations on incredibly tight stenosis, and the patients would get worse. I'm going, what is going on? So we have very few of those patients anymore. Medication, people will have a 10-hour surgery, and they'll be on Tylenol within 2 weeks. It's unbelievable how much less postoperative pain they have when they understand pain in general. And then they're much more proactive. They're in their rehab, they're ready to do the next step, they're reading, they're writing, they're doing all sorts of stuff. It's just a much more dynamic, energized process. So my definition of conservative care that you have to fail is that the central nervous system is calming down, the stress questionnaires are normalizing, they're sleeping, they have clear goals, they understand chronic pain, and their medications are now stabilized. I want the soft tissue work optimized. That's where we want the back pain gone first, and the structural problems defined. And I used to say, well, look, let's take this structural problem. So if you go to the dentist with a tooth that looks like this, how can you rehab that? So in my book, I say, look, if you have a patient who's emotionally compromised and they have a structural problem, do the surgery first because they can't tolerate the pain, as well as somebody who's more emotionally together. What happened is that when we started this prehab protocol, and I counted it up this morning, it's up to 40 patients that had structural problems, matching symptoms, that we had planned surgery, and we did the prehab process. They came in for the preoperative appointment, and they were fine. Pain was gone, completely gone. These are major, major structural lesions. So let me tell you about the conversation. This is the second part of the deal, is that the first point I want to make is that, by the way, this is the standard of care, right, Howard, Dave? I mean, this is the standard of care. It's been there all the way along. So the conversation I had says, look, your anxiety is like 10 out of 10, and your pain is also very high. What if I could magically get rid of your leg pain and you were left with the exact same anxiety you have right now the rest of your life? And they go, that would be terrible. Then they grab their leg and go, well, by doing the surgery, doesn't my anxiety go down? And they go, no. So I go, what if I get rid of your leg pain? I'm sorry, get rid of your anxiety, and you have to deal with this leg pain. What would that be like? And they go, well, that would be great, but I could sort of deal with that. People don't like raw anxiety. It is terrible. And that's the biggest paradigm shift I've had over and over again. I've had 4 patients last week. When you actually ask them the question, particularly these macho policeman type guys, they can't use the word anxiety, but it comes out. So if you ask the right questions, they're really complaining about anxiety. So as Howard pointed out, physical pain and mental pain I now treat as exactly the same thing. And I had a patient who had an incredibly straightforward problem. If you right here, this is an L5S1 isthmic spondylolisthesis. Here's the foramina, here's the nerve, here's the fat around the nerve. Looks fine. Look at this. Okay? No nerve root, there's a big disc in the foramina. He was 80 years old, and he was so straightforward, owned his own business. He looked like he's about 60 years old. I have to say that carefully now because I'm 62, but he looked about 60 years old. And I go, we'll just do the surgery, be a one-level fusion. It's hard to get to this spot without a fusion. So we do a one-level fusion, just get it done, get him back to work. So I broke my own rule. So as I was walking out of the room, he goes, my son just died. I'm going, what? He said, not only was he my son, he was my business partner. So his son had been killed in a tragic car accident about 3 months earlier. And I said, look, I'm not doing your surgery. I don't do surgery in face of severe stress. So I said, here's the book, start your writing exercises, and we'll just see what happens. So he calls me a week later, says, I want the surgery. Okay, fine, but please start the writing. He comes in for his preoperative visit, and he goes, I'm feeling a little bit better. Do you mind if I cancel the surgery or hold off on the surgery? I saw him back a month later, no pain. 2 years later, I looked on his chart last night, no pain. Pain is gone. This is a major structural problem. This L5 radiculopathy, perfect match. He would have done well with surgery. I mean, he would have done fine. But guess what? He still would have been grieving for his son. Another lady I saw as a second opinion about 3 months ago, and I knew her father had just passed away. She had this bone spur right here. It's a big bone spur. This is the left foramina. Here's the right one. She had a C6 radiculopathy, perfect match, okay? She's on the schedule for one-level fusion. And I said, look, let's just wait. We'll do an epidural, give you some time, and 6 months later, she's pain-free. Never had the surgery. This is my record so far. This is what actually got me fairly panicked, seriously, about maintaining a surgical practice. This is a normal spinal canal. Here's the nerve roots. This is this guy's spine. He's 66 years old. I actually moved his surgery up because he was so miserable in a wheelchair. Hunter, all sorts of stuff. You name the same thing. And here's his MRI scan at L3-4, and there's nothing, no white. I mean, that's extreme stenosis. He canceled the surgery. He's back hunting elk with that stenosis. So this whole interpretation of pain is very, very interesting. So in summary, basically, surgery performed for nociceptive pain cannot reliably work as chronic pain exists in the emotional centers. Spine surgery is unpredictable at best, even with structural problems. The data we know that's been around for at least 60 years is absolutely being ignored. Surgery can induce chronic pain. It's not usually mentioned as a complication. The risk factors to this room particularly are well known, but they're not even being assessed anymore. And if you look at the fact that we now become a business of medicine, actually pushing procedures that really have been documented not to work, we're actually creating disability very, very quickly. I think the medical profession right now is the #1 factor in creating disability in the US right now, period. They trust us, we are not honoring that trust. So by addressing all the variables that affect chronic pain, sleep, stress, medications, conditioning, and overall game plan, plus education, and actually talking to our patients, treating and preventing chronic disability and pain is incredibly rewarding with or without surgery. So let's just take what we know. Let's just do it. We already have the studies. We know we've been actually doing it in this room for quite a while. And the data is so clear and the results are so successful. Let's just do it. Thank you.